So you can diagnose circadian sleep disorders through either sleep logs or actigraphy. Light therapy is the preferred intervention. So if the problem is getting to sleep at night, you want to prescribe 30 minutes of 10,000 lumens of light. And again, the light boxes can be at the side. You don't have to be staring right at the light box. They just should be on the side, but close enough to your vision to provide retinal exposure. Then conversely, if somebody has problems maintaining sleep, then that is 2 hours of light therapy early evening, basically. You can also add low-dose melatonin. So you start off low and let the patient know that's not going to work immediately, because everybody says, well, I took this, Xanax or something and put me to sleep right away. Melatonin won't do that. It's going to take several days to weeks to kick in. And then if it doesn't work at the lower dose, then you gradually escalate it. You can use melatonin receptor agonists, particularly if there's low vision or blindness in the older adults. So that's an FDA-approved intervention. In terms of REM sleep behavioral disorders, this is associated with excessive motor activity at night. I've got a little photograph here by Henry Fuseli that talks about the demons in your nightmares. This is often associated, this condition associated with Parkinson's and Lewy body dementia. And these are the individuals that come into clinic whose wife has a black eye from being hit in the middle of the night, unbeknownst to the patient, or that they get leg injuries and so forth. So this is required to have polysomnography to make the diagnosis. So for the REM sleep behavior, the treatment is melatonin. In either Parkinson's disease, I'm showing Muhammad Ali and his what we call punch drunk or pugilistica Parkinsonianism. The other treatment for these REM sleep behavioral disorders could be clonazepam, but those are to be avoided in the older adult, just simply because they have such a huge risk for falls and, like I say, amnesia. I want to turn a little bit towards cognitive disorders such as dementia and sleep issues. So demented older patients have more sleep disruption. They get up in the middle of the night more frequently. It's poor sleep efficiency. It's not as deep sleep, and it's overall just fragmented sleep. A lot of times they'll have that reversal of the wake-sleep cycle. So they're up at night and they're sleeping during the day. So some of the interventions for sleep disorders and dementia, you might want to avoid the cholinesterase inhibitors such as Aricept and rivastigmine because they may get vivid dreams and worsen their insomnia. We actually had a patient come in from assisted living with exactly that issue. She had just been started on a cholinesterase inhibitor for her moderate dementia, and so we discontinued that. The issue with sedative hypnotics is that they will increase falls and they don't impact REM sleep, so those are to be avoided as much as possible. And you might empirically evaluate for obstructive sleep apnea. The important point is that demented patients, certainly those that are moderate to mildly impaired, can indeed comply with CPAP therapy. And then finally, we would recommend bright light therapy depending upon what the sleep disorder is. If it's problems getting to sleep, it's bright light in the morning. If it's problems maintaining sleep later in the night, then it's bright light therapy in the mid-afternoon. Well, I don't want to go bit by bit here, but just suffice it to say that there are both negative outcomes of sleep efficiency using melatonin, as well as data that shows that it does work. There's these so-called sedative antidepressants such as mirtazapine and trazodone, and typically their sleep efficacy is at the lower doses, and so mirtazapine typically should be more towards the 7.5 dose, the trazodone closer to the 25 milligram dose, but some randomized controlled trials show neither of them are very effective as sleep agents. The only one that kind of intrigued me was this one at the bottom here, where memantine in Alzheimer's disease improved sleep quality. So just to reemphasize in terms of dementia, consider non-pharmacologic interventions. We talked about light therapy. So there's actually one study that showed rather than 30 minutes, they did 60 minutes of light therapy in the morning, and that improved their sleep. Dance movements with familiar music is also a therapeutic approach. In one European study, they did home visits and talked about sleep hygiene with those home visits. Increasing physical activity, particularly before dinner time, is going to improve sleep hygiene. And then in terms of pharmacologic management, I mentioned the memantine story, as well as melatonin as potential trials, as well as the other consideration of discontinuing the acetylcholinesterase inhibitor. If you're looking at sleep issues, also address the caregivers for the older adult. They do lose a lot of sleep, and again, they have similar problems with sleep hygiene. It is exacerbated by depression, and it can really lead to caregiver burnout. Well, this is kind of a little bit of a sidebar here. So as I was looking at whether heat therapy in a hot bath improves sleep, and there is some evidence that it does do that, I found this really fascinating study of a regular Finnish saunas in several thousand Finnish men. So basically using one sauna per day versus 5 saunas per week, so the range was from 4 to 7 saunas per week, and you can see the hazard ratio declines to under 0.4 for frequent sauna use. So if that doesn't give you an incentive for getting a sauna in your basement or elsewhere, I don't know what else will incentivize you. I want to talk about the hospital-based sleep disruption. Certainly the loudness of the environment contributes to that. People are waking the patient up at all hours, either for medications or for vital signs. So noisy, you're bed bound, it's encouraged that you stay in bed as opposed to getting up and around. And there might be new medications that are going to disrupt your sleep. Tethers, whether they be IV or urinary catheters, can also be a problem for sleep disruption. The approach is somewhat similar, with some other considerations for dealing with the older adult with generalized sleep disorders or biorhythm, circadian rhythm disorders. So applying bright light. I don't know if you've prescribed bright light before, but it is something that can be considered in the hospital setting. Changing the morning medicines to a later time period as opposed to 6 o'clock in the morning, which may not coincide with the person's usual circadian rhythm. I want to point out to try to avoid diphenhydramine because that leads to an increased risk of delirium, particularly if there's other anticholinergic medications on board. You can also prescribe melatonin, again with the caveat that it's not going to work immediately. It's something that may take a couple of days to kick in, if not weeks. The point here is, as part of the Choose Wisely campaign from the American College of Physicians, is to avoid sedatives as a first line of therapy. You might consider nighttime use of Tylenol and also other non-pharmacologic therapies such as topical Voltaren or other liniments, ointments, lidocaine patches that might address nighttime pain. And then keep an eye on the patient. Let the nursing staff know, as well as others, to try and keep the older adult up during the daytime and encouraging physical activity as best they can. And simply just sitting in a chair and doing arm cranks in ergometry is beneficial. And then for chronic symptoms for insomnia, that typically needs to be referred to a psychologist for cognitive behavioral therapy, where they go through an actual sleep deprivation schedule to get the person's sleep pattern back on the tracks. So to encourage sleep hygiene, these are some of the things that you might put in your electronic medical record smart phase or handouts, brochures, whatever, to encourage the older adult to maintain a regular rising time, to use bright light therapy according to their symptoms, avoid napping, exercise, and to do so before dinner. Also, to discourage reading or TV in the bed. The bed should be for sleep only. To also prep yourself 30 minutes for bed with mental relaxation, whether that be meditation or reading a non-tablet, like a regular book, would be useful. And then also applying white noise at the bedside. A big one is eliminating or at least reducing alcohol. See about caffeine. A lot of times people don't always think about their Coca-Cola as being caffeinated, and certainly nicotine use, whether it's chewing tobacco or smoke, all can be stimulants that disrupt sleep hygiene. Again, trying to prep before bedtime, about a 30-minute wind down of some sort. You can also consider environmental elements that such as earplugs or eye shades. Certainly here in North Dakota, for example, during the summer when it stays light up until 11 p.m., 12 p.m. at night, getting eye shades may not be such a bad idea. Also consider body comfort, so warm feet might be just simply putting on a good pair of woolen socks to help keep the feet warm as a sleep hygiene intervention. Importantly, if you can't get to sleep within 30 minutes, the recommendation is to get up and get to another room. Don't stay in the bedroom. Either do some meditation or do some short reading, and then try to readdress your sleep with all the other elements that we recommended here just a short time ago. Some of the non-pharmacologic interventions for sleep hygiene basically are listed here. The points that I want to make is the idea of reconditioning. Some of these are, again, through the bottom here of cognitive behavioral therapy to reset the sleep cycle. But I think the most important prescription that we can do is to offer light therapy here at the bottom of 10,000 lumens. There's actually a technique where you tense and relax each muscle group. So you start from your toes to your feet to your calves. So you tense them up and then relax them, going all the way up to your jaws and temporal masseters and neck muscles, for example. So that's a technique that you might instruct your patient to do as part of a relaxation routine as they go to bed. So these are just some of the examples here of what to expect. So the stimulus control, where the patient is instructed to go to bed when they're sleepy, and to basically use the bed for sleeping and not for other activities. Also to try and avoid nighttime snacks shortly before sleeping. The sleep restriction is a opportunity to offset the sleep, so you shorten the sleep stay and then you increase it by 15-minute increments. The cognitive interventions, basically these include things like imagery, education about some false beliefs about sleep, and it's important that with these individuals, you have to be mindful of them being cognitively intact, because the demented patient does not really respond to rationalization or argumentative type discourse. So always remember that in the cognitively impaired individual, older adult, you always go with the flow. You don't challenge them. So those cognitive interventions aren't going to work so well in the demented patient. We talked about relaxation techniques, so whether it be a massage, vibration, a warm bath, hot shower, for example, and then also mental imagery, or just meditation, focusing on your breathing alone. These are all relaxation techniques that we're familiar with. So try to avoid the sleepers, all sedatives, as well as SSRIs, the sedating SSRIs, all the antidepressant medication class increase the fall risk by 1.6 to over 2 odds ratio considerations. So these sleepers also contribute to amnesia, and long-term use may lead to dementia. Be careful with them, because they can be associated with rebound and withdrawal syndromes, and there's a lot of somnolence and daytime carryover, because some of the even short-acting are not as short-acting as we may think. So these are the different medications that you could consider. Again, the trade versus the generic name. You can see the starting dose for those and some of the side effects. So it turns out that there was a study done on zolpidem that within 30 minutes of taking the medication, the older adults that were studied had a postural instability that was about the equivalent of a drunken sailor. It really was quite impressive that no sooner did they take the medication than they had a tremendous gait disturbance and postural imbalance that was made worse by perturbation. So the melatonin receptor agonists are listed there with some of the side effects over on the right-hand column there. And melatonin is basically the preferred intervention. And Cevoxarent is another medication that can be considered. I don't have a lot of clinical experience with this, and again, it has considerable side effects and carryover effects into the day that might affect driving. The low-dose SSRIs are listed here. Again, just the point of view that they can be associated with fall risk and next day driving impairment. So if you have individuals that are on chronic benzodiazepines, it increases overall their morbidity and mortality, and overall it will get short-term benefits, but it'll exacerbate sleep problems over the long run. And it's really hard to convince people of that. They really do have a true dependency for some of these individuals that have been taking these benzos for many, many years. To deprescribe, it's important to do low and slow. So you use half the dose every 2 weeks, or even a slower taper. Sometimes I've used every month to try and decrease the amount of medication that they're taking. So just words of caution. I mentioned Tylenol at bedtime for pain control, but avoid Tylenol PM. Why? Well, because it's the second line there. It contains diphenhydramine or Benadryl. Try to get people to reduce their alcohol intake, and just point out that some of these over-the-counters such as Valerian and Kava really are not effective as sleep aids. So just to summarize, You can use polysomnography for individuals that are not responsive to your sleep intervention as to however you diagnosed it, just with the caveat that you don't use polysomnography for restless leg syndrome. And I just reemphasize that because I've seen that on the boards previously. Non-pharmacologic interventions for both insomnia and restless leg syndrome include bright light therapy, melatonin, and all those factors we talked about with sleep hygiene. And this is just to summarize some of the references that we have, that I cited in the presentation. So I appreciate your attention, and I hope you've learned a little bit more about how to evaluate and treat sleep disorders in the older adult population. Thank you for your attention.